Hello, this is Dr. Amy Toon, and I'm going to be talking about ears, nose, and throat examinations. When you start the ear, nose, and throat examination, you're going to go ahead and start with the head and talk about the anatomy and remember to think about the anatomy and the physiology and review of the related history, examinations, and findings. Some of the questions you would like to ask is a present problem or what brings them into the clinic today. And things that would happen under this category would be a head injury, headaches, stiff neck, thyroid problems. Past medical history could be head trauma, treatments of around the head and neck, surgery, seizures, thyroid problems, personal and social histories such as risk, intentions, nutrition, alcohol, or drug use, and family histories like headaches, as over 50% of migraines are familiar, as is the same with thyroid problems. Special populations are going to be your infant, pregnant women, and older adults in most of the categories of assessment. And one of the things you want to ask about infants is the prenatal history. You want to find out if they had a 3-vessel cord or a 2-vessel cord, and because that's going to lead to a lot of problems with the ears and the kidneys if they just got a 2-vessel cord. And look at the birth history, unusual head shapes, the quality of the head control and the strength, and acute illnesses, congenital abnormalities, neonatal screening for congenital hypothyroidism, and that's usually done if they were born in a hospital. If they weren't, they are to go to a pediatrician and be tested for hypothyroidism, and the reason behind this is untreated hypothyroidism for 6 months can lead to mental retardation. So this is a test which is often repeated. It's first done in the hospital when at birth and often repeated on that 2-week visit, so there will be none that falls through the cracks. Pregnant women, you want to ask them about weeks of gestation or how many weeks they are postpartum, if they had any pre-existing diseases prior to being pregnant, if they had a history of pregnancy-induced hypertension, alcohol use, drug use, medications, both prescription and over-the-counter. And with the older adults, you're going to look at if they're dizzy and if they have head and neck problems. With hyperextension of the neck, it's not that unusual, especially if they're flexed at the waist and hyperextended at the neck, to have problems with dizziness. And that will happen as the cervical canal gets more arthritic as they age. The equipment you're going to need for the examination are tape measure, stethoscope, a cup of water to be able to feel the thyroid when they swallow, and some kind of transilluminator. The skull is composed of 7 fused bones, 2 frontal, 2 parental, 2 temporal, and 1 occipital bone. It has facial cavities for the eyes, nose, and the mouth. And when you look at this skull, you're going to realize that there's suture lines, and these suture lines are not going to totally ossify until adulthood to allow the brain to grow and the skull to move with it. The skull is these bones right here that are movable, that are these are the names of the bones of the skull. And the mandible is the one movable bone. Major landmarks of the face is the nasolabial folds and the palpable fissures. Facial muscles are innervated by the cranial nerves, 5 and 7. You have a temporary artery is the major accessible artery of the face. So I just wanted to let you see right here the palpable fissures and the nasolabial fold, or some people will call it the sides of the smile fold. What you want to do on the face is look at the head position, facial structure, symmetry, cranial nerves, and skull size and shape, the scalp and hair, temporal areas, and salivary glands. You're going to percuss the skull if indicated. For some reason you think that, especially in an infant, you would percuss that if you're concerned about hydrocephalus. And you're going to auscultate only if indicated, and that would be on the temporary artery. Just to review, here is the anterior view of the major veins of the neck and also of your thyroid cartilage. You realize when you look at this picture that if you're having any tracheal tug, what you're going to worry about is that they've got some kind of aneurysm, aortic aneurysm, because you can see the arch of the aorta is very close to the trachea. So if they have an aneurysm, a tracheal tug, especially if it's got pulsations to it, you're going to think aortic aneurysm. You realize that you're going to have the thyroid gland, and one of the main veins that go right by it is the internal jugular vein, and that drains into, lost my pointer, it drains into the subclavian veins, right and left. Side view of the throat, just to get your positions. The hyoid bone is at the very top below the mandible. Your thyroid cartilage, cricoid cartilage, thyroid gland, and your trachea. When you look at this picture, you realize you've got the clavicles right about in here. The other part of this picture that's cut out is the sternocleidomastoid, and realize that you've got an internal carotid artery and an external carotid artery that is on the side of the neck. So you want to palpate and inspect. First you inspect, then you palpate, then you percuss, and the last thing is you're going to do deep palpations. You don't really auscultate the neck outside of the buries in the carotids, except if they're having pain when you touch the temporal area, and then you'll listen for a bury there over the temporal artery. You will also listen for a bury over the thyroid if you find an enlarged thyroid. And that's why I'm leaving auscultate out for the head. There's symmetry of sternocleidomastoid. You want to make sure it's the same on both sides. And of the trapezius muscle, if there's alignment of the trachea. And you want to look at the range of motion of the neck and palpate the lymph nodes. So you need to know your anterior triangle, and it is divided by the sternocleidomastoid, the big muscle between the ear and the sternum. And the posterior triangle will be behind the sternocleidomastoid and above the clavicle. The head, you observe head position, if it's tilted, if there's a tremor. You inspect the scalp and scalp for the size, the shape, the molding of it, symmetry, lesions, and trauma. You want to inspect facial fissures, including the following for symmetry and shape, unusual features, tics, characteristic facies, and that would be facial expressions, or not expressions, facial characteristics that would be typical of certain disorders, is what they're indicating there. Pallor and pigmentation variations. And an example of that would be your mask of pregnancy, would be one of your pigmentation variations, or rosacea. You also want to palpate the head and the scalp, noting the following for symmetry. If there's any tenderness, particularly over areas of frontal and maxillary sinuses, if there's scalp movement, if the sutures or the fontanelles are closed. Now you realize the posterior fontanelle will close by about 2 months. So even babies remember to cover their back. They do their posterior first. The anterior will close. It's a much larger fontanelle. And it will close about 2 years old. It's not unusual that you might feel the fontanelles, and you want to make sure that they're not bulging at any time. Bulging outward. You want to look at the hair, the texture, and the distribution thereof. And when you're looking at the hair, realize that one of the main reasons that infants lose hair is tinea capitis, and a fungal infection of the scalp is what that is. And there's assorted reasons why adults lose hair, and there's the male pattern baldness that has temporal loss and over the crown of the head for male pattern baldness. And there's thyroid disorders will also cause you to lose hair. The other big thing that's going to cause you to lose hair is if you've had any kind of major stress, any burn, a really bad acute illness, chemotherapy, the hair will come out. You want to find out if it's coming out all over or just in one location. And if it's just on the predominant side of particularly children, particularly girls, sometimes they got trichotillomania where they're twisting their hair, and it looks like they're pulling it out, but they're breaking it because they're twisting it. Another reason why hair falls out is with over-tension of the hair follicles, and they break. And this happens when some girls braid their hair very tight, or some boys braid their hair very tight. And as they undo these braids, or while they're braiding them, they break the hair. Okay, back to the head. When appropriate, you're going to auscultate the temporal arteries and palpate, noting the following: thickness, hardness, or tenderness. And on the temporal arteries, if you palpate the temporal arteries and there's any kind of pain there, you need to take note of that, because you don't want to let temporal arthritis go on. You treat it with steroids, but if you let that go untreated, it can end up in blindness. So it's pretty serious. You need to jump on that. You're going to inspect and palpate the salivatory glands, transilluminate the skull of infants with a rapidly increasing head circumference. So what's rapidly increasing head circumference? Well, if you remember the head circumference chart you get from the CDC, the Center of Disease Control. And if everybody's got a line or trajectory that their head circumference should be going on. If for some reason their growth does not stay along their line and goes to the next line up, you need to really palpate that scalp and make sure there's no edema on it. Talking about edema on a child, or actually an infant's brand new baby, just delivered. Will their scalp have a little edema? Often in the presenting part when they had a vaginal birth. And that tends to go away in days. So by the 2-week checkup, when most nurse practitioners will be seeing the child for the first time, that edema should have abated. All right, you want to palpate the thyroid gland for the following: size, shape, configurations, consistency, tenderness, nodules. If the gland is enlarged, auscultate for bruits and evaluate the range of motion of the neck. And you're going to flex, extend, rotate, lateral rotation of the neck. The thyroid gland. Inspect and look for any enlargement. Normally, you're not going to see the thyroid. Realize, however, it's a normal finding. If you are able to palpate, realize the right side can be 25% larger than the left side. And that's a normal finding on people. That doesn't mean that there's anything wrong, but the right side tends to be a little larger than the left side of the thyroid in most people. You auscultate if enlarged or nodule and see if you hear a bruit. To be able to hear better, though, it's easier if you just tell the patient to hold the breath, and you'll be able to hear better. You should not hear anything. But if you ever hear a bruit, it will sound like bruits, like on fistulas. It's just a sound, which you normally wouldn't hear. So here's how you can do a thyroid exam from the posterior. And what I do is most people have two lines in their neck from their skin folds. Put your fingers flat in between those two lines of the neck skin folds. Pull them back, just pull them straight back, and then you're going to deviate the trachea and the thyroid to one hand or one side, and you're going to palpate with that one side as you have the patient swallow a little sip of water. You should feel the thyroid. It might just go up and back down, and you're trying to see, is it symmetrical? So how big is this thing, and how thick is the thyroid? If you will imagine the size of a quarter and the width or the thickness of a quarter that just slides up and goes down. It's about that size. Okay, if you want to do the anterior, and this works better with small children because they don't like to have their neck grabbed, and for people with psych disorders that might have anxiety and they don't like you to go behind them and grab their neck, you're going to do an anterior approach, and you're doing the same thing, but you're using your push to the left with your right thumb, and your palpate with your left fingers. And you're going to still try to feel the exact same thing. In this picture, she's using her left thumb to palpate. I use my fingers because if I use all four fingers, I got more surface to feel than just my thumb, and that's why I use my fingers. In this picture, I think everybody can see this is a quite enlarged thyroid. The right is bigger than the left by a lot more than 25%. And this is a lady that's got obvious goiter. And we don't know if it's iron deficiency, but that's a strong suspicion. Special populations on the head. You're going to, infants, remember the head circumference. Remember the fontanelles. The posterior fontanelle closes at 2 weeks. Anterior at 2 months. I'm sorry. I said that wrong. The posterior at 2 months. The anterior at 2 years. Look at the suture lines. Look to see if they've got any kind of cephalohematoma. And a cephalohematoma would be a blood underneath the skin or the scalp, but it doesn't cross any suture lines. And you transilluminate that if needed. Children, palpate the skull, note shape of the skull and thyroid gland. Pregnant women, chloasma it's a word that I've always wrestled with. Chloasma is the pregnancy mask, and you're going to see a darkening And this usually happens around week 12 of pregnancy, and it tends to be a darkening of the pigmentation of the face, often on the forehead. They can have thyroid enlargement and a bruit with pregnancy. On adults, realize there will be sagging facial musculature and decreased range of motion of the neck. They can have a fibrotic thyroid. Everything gets kind of fibrose as you age. And hyperextend the neck might cause dizziness, especially if they're bending over. That's pretty typical. All right, headaches. There's different types of headaches that we're going to cover. And the headaches basically are going to be a little later, but it comes down to headaches can be a migraine headache. Migraines tend to be unilateral in adults. They're bilateral in children. And then you can have a cluster headache, which tends to be behind the eye, and they come in clusters. You might not have any for 6 months, and then you have 4 or 5 in 2 days. So they come in clusters. The other thing is you can have a tension headache, which starts on the trapezius and goes up the occipital area, both sides. You can also have a hypertension headache. When you have high blood pressure, you're also going to have a pulsating headache. Okay, and with that, some people will say they hear their blood pressure, they hear their pulse in their ear, and that would be typical of a hypertension headache. You've got different facies that if you look at page 246 to 248 in your book, you've got a lot of those listed. And from Cushing's syndromes, and you've got the pictures of them and the descriptions in your book, and the fetal alcohol syndrome. And they really tell you in the book what you're really looking for. Okay, parotid gland tumor is where you're going to have that. And now this can be right at the temporomandibular joint area and a little lower, below the mandible. Paget's disease of the bone is where you've got bossiness of the bone, and this lady's got it in her forehead. And this is a typical Paget's. Bell's palsy is another facial abnormality. This is on this lady's left side. And you see that she's smiling, but the left side doesn't move. What you want to note is this only from the cheek down. That's going to make you think it might be trigeminal versus Bell's palsy. If it's the entire face, and it's not on this lady because you notice the eyebrows are symmetrical. And if they didn't blacken the eyes, you'd notice the eyes look symmetrical. But if it was all over one side of the face, you would think more of TIA or stroke. But on Bell's palsy, it tends to be just from the cheek down. And this is something that you can rapidly treat with steroids and make a real difference in the people. Other common abnormalities of the neck is a thyroid glacial cyst. And if you will look in your book, you've got good pictures of that. You can have a brachial cleft cyst. You can have wry neck. And you've got a picture of wry neck in your book also at the end of the chapter. And a salivary gland tumor. Now that's sometimes hard to tell the difference between a parotid tumor and a salivary gland tumor. And how you do that is the salivary gland tumors often are bilateral, and more so than the parotids. But either one, you're going to go ahead and just look at the size, see how thick it is, if it feels irregular, and you would do a soft tissue CT with contrast to be able to tell what kind of tumor you've got there. And some of the things they used to do on the head, like percussion of the head, they don't do that as much now because of the commonality of CT scans. But to tell a salivary gland tumor, you would do a soft tissue CT of the neck. Okay, common abnormalities, thyroid glands. You can have hypothyroidism, where your thyroid's underproducing, hyperthyroidism, myxedema, Graves' disease, which is also hyperthyroidism, and Hashimoto's disease. Now, what's the difference between hyperthyroidism and Graves' disease is often for many splitting hairs, but Graves' disease has been there for a very long time, and it tends to have more irreversible components to it. Hyperthyroidism might be a slight hyperthyroidism, but Graves' disease tends to be around longer. But hyperthyroidism and Graves' disease are essentially the same thing. Infants and children, they can have an encephalocele, they can have microcephaly, they can have craniostenosis where the suture lines of the skull becomes fused. And they can have, it's common that they have bruits in their anterior fontanelle, or you're going to hear bruits in the kids over the fontanelles until 5 years old. That is not a big deal. You want to just really watch the head circumference on these children. You can percuss the skull with one finger to detect if it's got McEwen's sign, and that's a stronger resonant sound with either hydrocephalus or brain abscess is present. But that's not done near as often now because you're doing a CT. Thyroid may or may not be palpable on infants and children. On this little boy, you see that he's got Down syndrome. The biggest thing that jumps out at you is the bridge of the nose is almost non-existent. It's just really decreased. He's got the Mongolian slant of the eyes. And if you were to look from the outer canthus of the eyes towards the upper pinna of the ear, you're going to realize that the ear, if you were to turn this head sideways, it would probably be right, barely touching the ear or a little low. And he has a large tongue, and that's often common because the mouth is always open and the tongue is partially protruding. On this fetal alcohol syndrome, there's two things that are just classic. You're going to notice the wide bridge, the wide set eyes. They just hit you as pretty wide on the face. The other thing that you're going to know is he has a poorly formed philtrum right here underneath the nose, the little bridge in the middle of the upper lip. You just don't see it very much. And he's got a short nose and a relatively thin upper lip. Classic alcohol syndrome. And this is one of the most common acquired mental retardations is due to fetal alcohol syndrome. Okay, the heads. I went ahead and talked to you about migraines, unilateral in adults, bilateral in kids. And 50% of the adults with migraines, their children, will have migraines. They come in clusters, are often behind the eye. The bad thing about cluster headaches is people get very frustrated with them, and it has the highest suicide rate out of all these headaches. But the good thing is that they're usually treatable with high-dose oxygen. But this is not a normal oxygen container. It has to go up to 12 to 15, instead of just the typical 5 that you'll see in the hospital. They'll go up to 5 liters. But these that you would treat a cluster go up to 12 to 15. But once the people realize how the oxygen can make a difference, they will love you for writing that prescription. Hypertensive, it's pulsating. They often hear it in their ears. Muscular or tension headache starts in the occipital and moves up. Temporal arthritis is only over the temporal area, and it's more painful with palpation, where you tend to rub your temples just to relax sometimes. That is where the temporal arthritis will be. And the salivary tumor, the salivary gland tumor is a tumor of any of the salivary glands, but most commonly in the parotid. They're slow growing. Another one of the facial things that we notice is a butterfly rash of systemic lupus erythemus. And it's a butterfly rash that goes over the nose and over the cheeks. And this little girl's got one. This picture's got a little bit of glare on it. Okay, thyroid glossal duct cyst is a palpable cystic mass in the neck. You can have a brachial cleft cyst. It's a congenital neck formed by incomplete involution of the brachial cleft. And then you can have wry neck, birth traumas, tumors, and or just trauma, cranial nerve palsy, muscle spasms, infections, and drug ingestions can all lead up to wry neck. Okay, hypothyroid is the underactive thyroid. Hyperthyroid is overactive. And myxedema is skin and tissue disorder, usually due to severe prolonged hypothyroidism. And it's sad because it's something very treatable. All right, here's the thyroid enlargement that's not so obvious. And this is a typical thyroid enlargement in pregnancy. Why do you know that this is abnormal? The left is bigger than the right. Thyroid size increases in pregnancy in areas of iodine deficiency, but not in those with sufficient iodine. In the United States diet, most of the iodine is put into salt. And it's in the countries where the salt is harvested from the sea and there's no iodine added that it's notorious for iodine insufficiency. Iodine is also very high in shell, seafood, shrimp, lobster, that kind of stuff. Things that come in shells. All right. Myxedema facies, it's the puffy yellowed skin on this Hispanic-looking man. And it has sparse hair and temporal loss of the eyebrows, but his look pretty thick. Okay, here's the hyperthyroid facies. The problem with this, bless this lady's heart, she will never get her eyes back to normal. She has eyelid retraction that is permanent because this was not detected early enough. Now, how do you know that this is eyelid retraction? Because on the eyes, and when I talk about eyes, I'll bring this out, but you should not be able to see the sclera all the way around the iris. You can see one or the other, but on most people, you cannot see both. Now, those from the Mediterranean, you'll be able to see the sclera around the iris, or the white part, all the way around the colored part. But most Caucasians, you're going to see the lid goes on the iris on both the top and the bottom. And that's going to be your first clue. If you can see anywhere, can see the sclera all the way around the iris, or a good part of the iris, that should be letting you know that there's some eyelid retraction. Okay. Graves' disease, autoimmune, and antibodies to the thyroid stimulating hormone receptor, and it leads to an overactive thyroid. And Hashimoto's disease is also autoimmune antibodies against the thyroid gland, and it often causes hypothyroidism. All right, let's change from the neck to ears. So I put these jokes in to be breaks between major shifts in topic. So now we're going to ears. Okay, again, you're going to review the anatomy and physiology and related findings and the examinations. Okay, what do we really want to ask on the history? About 90% of your diagnosis is from the history, so you really have to get a good history. Ask about dizziness, vertigo, head, earaches, hearing loss, nasal discharge, snoring, nosebleed, dental problems, mouth lesions, sore throat, or difficulty swallowing. So why are we asking all this? Because if you're dealing with ears and you've got dizziness or vertigo, you're going to wonder about the middle ear. If they've got an earache, it's often the outer otitis externa. If there's hearing loss, you want to find out, is it from conduction or is it sensory neural? If there's nasal discharge, you're going to wonder, is it postnasal drip? And if you've got nasal discharge, you're going to have backup, usually of the mucus in the nose, and that can cause problems with the eustachian tube. If they're snoring, you want to know that because often that might be because they've got enlarged adenoids. If they're prone to nosebleeds from dry nose or from hypertension, dental problems. One of the biggest dental problems can be caused by just dry mouth, and that's related to snoring. If they have any kind of mouth lesion, sore throat, to find out if they've got any infectious diseases, or difficulty with swallowing, which often happens with neurological problems. Past medical history. Systemic diseases that you'd really want to know about, and if any of them had to have a mycin, any drug that ends in the suffix mycin, history of the ear, nose, throat, sinus problems. You want to find out the family history if there's any hearing loss, because a lot of hearing loss, especially sensory neural, is genetic. And if your dad's 60 and he loses his hearing, well, you got pretty good odds that you need to be careful with your hearing and not have loud music, because around 60, you're likely to have problems. So those are the people that you really want to use good ear protection if they're around loud noises all the time, or gunfire, or just loud noises. Allergies, and if they've had any renal diseases. And this goes back to often if you've got a 2-vessel cord when you're born in the umbilical cord instead of a 3-vessel, you have renal problems and you have hearing problems. Personal and social history, if there's any hazards, noise hazards, if there's any problems with nutrition. The biggest problem with nutrition is dentation. If you don't have some teeth to chew protein up, you tend not to have a lot of protein, because protein takes chewing. So does fiber in a diet. Do they do good oral care, tobacco and alcohol and drug use? Okay, the other part of the history that you really want to get is the maternal history, and you want to make sure that there's been, if there's prematurity, you know how many weeks. If there's been any kind of erythroblastosis fetalis or infections, if the mom's breastfeeding, if there's any environmental risk in the family, loud noises, if there's any congenital defects, the biggest one would be for latching, if they have cleft lip. Behaviors indicating hearing loss, like the child doesn't pay attention until you get right in front of them. And if they have problems with dental care, because the dental home is supposed to be established at 1 year old. And I don't know of many 1-year-olds that go to a dentist, But anyhow, that's the recommendation, to get the child to not be afraid of the dentist. Pregnant women, you're going to ask about the weeks of gestation or postpartum, symptoms before pregnancy, and dental care. In the older adults, you're going to ask about hearing loss, physical disability, if they have difficulty chewing, if there's a deterioration of the teeth, and if they have dry mouth and their medications. And a lot of the medications are going to be anticholinergics, and they're going to give you the dry mouth. If there's a deterioration of the teeth, they're going to have problems with dentation. But one of the biggest things is, if they have weight loss, which is typical as you age, of greater than 10% of their total body weight, none of their dentures are going to fit real well. So they quit chewing foods that take a lot of chewing, like beef, chicken, because it's hard because their teeth are loose. So sometimes it's simply getting a new set of dentures, as for people that lose a lot of weight. Okay, what you're going to need is an otoscope with a pneumatic attachment, nasal speculum, tongue blades, tuning forks, gauze and gloves, pen lights, and vials with different odors. The inner ear, there's a vestibule, semicircular canals, the cochlear, and the cochlear transmits sounds to the 8th cranial nerve. There's the semicircular canals involved in the vestibular functions. And you want to look at the external canal, and on the otoscopic exam, look at the external canal and tympanic membrane and do a hearing evaluation on everybody. So, as you enter the external canal, one of the biggest things you're going to do is on somebody that is 1 to 2 years old, definitely under 1 and up to 2, you're going to pull down on the pinna. On anybody greater than 2, you're going to pull up and back. On those that are less than 2, you pull down and a little back. And you want to use the biggest speculum that you can get in the canal easily. And you want to look at the tympanic membrane. You realize that the malleus, incus, and the stapes are the 3 bones that need to vibrate in order for hearing to occur. All right. We just went over this. The big thing about the pinna and the external functions of the ear is protection, to where things cannot perforate the tympanic membrane, and they also gather sounds. So when you look at an ear, right before the ear is the tragus, and right on the back side of that is the antitragus. The lobule is on the bottom, and the helix is on the top. And so you need to know these terms to be able to discuss your ears and chart accordingly. Okay, middle ear structures. You've got the ossicles, the malleus, incus, and stapes, tympanic membrane. And on the middle ear function, you can have, the middle ear is divided by the tympanic membrane from the external ear. And if that tympanic membrane is not intact, it is very likely that an infection will get into the middle ear. One of the reasons why that's so likely is just due to the fact that the ear canal itself goes downward as a child until they get to start running, about age 3 to 4, and then it becomes more horizontal like an adult. And this is one of the reasons why children, before they get up and run a lot, around 3 to 4, have more ear infections than an adult does. Realize that hearing is an interpretation of sound waves that travel to the brain, and it can be sound can also be transmitted by bone directly to the inner ear. And this would be common in someone that hears their own voice. And they're hearing their voice, so they talk lower, and they often say that they hear very well in crowds. And that would be somebody that hears through bone conduction. Whereas somebody that has just typical sensorineural loss will hear worse in crowds instead of better. Past medical history, look for systemic diseases, and for the ear, look for childhood problems, surgery, Lamberitis, and if they have antibiotic use. The antibiotics you really want to look for are those that end in mycin, gentamicin, erythromycin, the mycin drugs. Past medical history, look for the nose, sinuses, and throat. I'm putting all these past medical histories together. Look for trauma, surgeries, chronic nosebleeds in the nose. Sinuses, look for a postnasal drip or repeated allergies or sinusitis. And the throat, look for frequent strep infections of the throat. And one of the big things on these strep infections of the throat, if the parents or if the person did not change their toothbrush after they finished the antibiotics, it is real common they reinfect themselves from that old toothbrush. So be sure to change the toothbrush. Tonsils and the adenoids. All right, the other family history, ask about hearing problems, Meniere's, allergies, because that's going to always have inflammation in this area and have fluid, more likely to have fluid in the station 2 that way, from the sinuses, and inherited renal diseases. Personal social, look for environmental, nutritional, tobacco, alcohol, intranasal use of cocaine. And this is the same thing twice. So this slide is repeated. It has infections, breastfeeding, secondary tobacco smoke, because that causes more ear infections, and because it causes more allergic response, and if they're in child care settings or if they're a stay-at-home child. Okay. Look for congenital defects where they're missing their milestones. If they're playing with small objects, and look at if they're dental care, the number of teeth, if they're a thumb sucker or pacifier use, because that's going to cause teeth abnormalities. Okay, so what you want to get is an otoscope, pneumatic attachment, nasal speculum, tongue blades, gauze gloves, pen lights, and the vials of different colors. Okay, what you're going to do on the external exam, you're going to look at size, shape, symmetry, landmarks, and position on head. You're going to look for the color of the auricles and the presence of deformities, lesions, and nodules. You're going to inspect the external auditory canal and look for discharge and odor. So you've got a picture here in your book that has got assorted abnormalities of the ear. And on the first picture A, you've got this, okay, you have this picture on 308. And so you realize that in picture A is a little different in the book. You can see it better, but it is a preauricular skin tag. And B is going to be, in the PowerPoint, the B and the C are switched. And so you realize that the B here is your Darwin tubercle, and your C is an auricular sinus, and in D is your trophi, and okay, F is the preauricular tag. D is squamous cell carcinoma. E is you've got a sebaceous cyst. And they've got this mislabeled in the book because that squamous cell carcinoma is D. Okay. One of the things you're going to look about the ears is to see where it is on the outer canthus of the eye. And you should have the top of the pinna or the helix to at least be on that line. And the other thing you're going to look at is on the side, you're going to draw a perpendicular and a horizontal line. Perpendicular is going to be right in front of the ear, and you want a 10% or less degrees in the cross sections of these lines, as it has in the book here. And why you want that is that's going to let you know if the ears are appropriate are normal on the side of the face, or if they're set posterior and if they're tilted back. And why you really care about that is that allows you to recognize some congenital abnormalities of children. You can get a temporometric configuration, and this is what you do to tell the patency of the tympanic membrane and how much it moves. And this is something that you're put in an ear. It prints out a little strip that looks like what you get at a grocery store register tape, and it's going to let you know how much does the drum or the tympanic membrane move. And that's going to let you know, is there fluid behind there? Is it even more than fluid and you've got some epithelial cells that are there? Or if it's perforated. And so this is how you can tell how much movement there is on an ear. And this is important, especially in kids that have just been crying. And you can't tell if the redness that you see on the tympanic membrane is because the baby cries, because it does get redder as they cry, or if there's any movement in the ear at all. I'm sorry, I said the ear, but it's really movement of the tympanic membrane. Okay, the examined findings on the ears, the external exam, you're going to palpate the auricles and the mastoid area for tenderness and pain, swelling and nodules. And you're going to look for consistency of nodules. They should be firm and mobile without, you're going to look at the consistency of the auricle, and they should be firm and mobile without any nodules on them. Okay, on an infant, on the ears, you inspect the auricle for full form and flexibility. So what you want to do is you want to get the helix of the ear and pull it forward towards the tragus and snap it back and see if it snaps back. If it doesn't snap back and it's a little floppy, that's probably a sign of prematurity. So on your ear, if you get your finger under the lobe and go up towards the helix, you're going to notice that midway your ear has more recoil than on the very top of the helix, and that is typical. Realize that the auditory canals should be examined in the first few weeks of life. Tympanic membranes become conical after the first months, and evaluate the infant hearing using sound stimuli like snap your fingers or clap and see if they're turned towards the noise. Otoscopic exam is used to inspect the external and internal auditory canal. You want to inspect it for discharge, redness, scaling, lesions, foreign bodies, and cerumen. And you're going to look at the tympanic membrane and look for landmarks, color, contour, perforation, and use a mnemonic attachment and evaluate the mobility and compliance of the tympanic membrane. And that's the temporometry that we just talked about. So, in this picture, the lady is grabbing this gentleman's helix, pulling up and back, and she's anchoring by putting her finger on the ear and going into the ear. Okay, on the hearing evaluation, you've got the, you're going to test the cranial nerve 8. and it's the hearing test. You want to do the voice whisper test, the ticking watch test, the tuning fork test, Weber and Rhine, and the Schwarzwarbach. Weber and Rhine are the two big ones. So what you're going to do is you're going to tap the fork and holding the handle and not touching the prongs of the fork, you're going to put the tuning fork like it has on the right hand side in the middle of the head, and you're going to see, does it vibrate on both sides equally? And that is normal. Then the second thing is the Rhine test, and you are going to tap it, put it behind on the mastoid process, and when they quit hearing it, you put it in front of the ear, and when they quit hearing that, you time it. Air conduction should be twice as long as the bone conduction. In this picture, picture A on the top left is testing bone conduction. Air conduction is going to be B, picture B. All right, so positive Rhine, or Rhine, depending on who says it. I've heard it pronounced professionally both ways. The sound is heard twice as long in the air conduction by the bone conduction. That's called a positive Rhine. -1 shows conductive hearing loss, and the air conduction is equal to bone conduction or less. Sensory and neural hearing loss. And air conduction is greater than bone conduction but reduced overall, and this is typical sensory neural loss that most people have with aging. And this sensory neural loss is the type of hearing loss where people cannot hear in crowds. Incidentally, men tend to lose their hearing and have sensory neural loss more than females. I don't know why. But maybe it's just selective hearing over time. Who knows? But anyhow, it's more common in men. Common abnormalities is otitis externa, otitis media, and cholestoma, where you have epithelial cells behind the tympanic membrane. Otosclerosis, Meniere's disease, and Lambert arthritis. So the other common abnormalities of the nose and sinus are sinusitis, cocaine use, and of the mouth is tonsillitis, peritonsillar abscess, and sleep apnea. Common abnormalities in special populations would be having the choral anal atresia for children, cleft palate, and cleft lip in the children. And that's because they haven't had the hard palate close, and that occurs usually at 12-week gestation. Older adults have presbycusis, or the sensory hearing loss deterioration, and that's the one where they don't have the air conduction, and they have harder times hearing in a crowd. And xerostomia. So let's review the bones of the inner ear. You got your short process here of the malleus, and then you've got the manubrium. And these are the two that you can see, the manubrium and the short process. So let's look at the umbo, and here's the short process of the malleus. Here is the manubrium. Your pars tensa is right back here. Conolite is right here. And this is a very typical pearly gray normal tympanic membrane. So, what do we have in these two pictures? In the first picture, we have cerumen. And cerumen comes in two types, wet and dry. Wet is a darker color. Dry, it's lighter, whiter, flakier. And it's more common in Native Americans and Asian Pacific Islanders. Everybody else tends to have this waxy cerumen, and it's genetic. If some people just grow a lot of wax in their ears. The purpose of the wax is to keep the bugs out from getting in the ear, so it needs to be there to some extent. So don't go wild on the Q-tips. And if you're not able to see the tympanic membrane, then you'd remove the wax. If you can see the tympanic membrane around the wax, leave it. Okay, the other thing that you've got down below is that is an ear tube. And so they come in assorted sizes, assorted colors, and as the tympanic membrane grows, that ear tube will come out. The average lifespan of an ear tube placement is going to be about 18 months. And as they come out, they just gradually come out. So sometime you're looking in the ear and there's a piece of plastic in there, somebody's tube. So just gently pry it forward to get it out of there. On otitis media, here's the normal color, pearly gray, and see how you've got extra erythema and on the top half of this tympanic membrane. That's the early stages. Here's the late stages of otitis media. And here's perforation, and we've got a hole right there. And so what we've got in the following, this is air bubbles behind the tympanic membrane. And this is real common on people that either pinch their nose and don't really sneeze, where they sneeze and it blows out their ears, or people that really force their ears, like they've flown recently and they're trying to clear their ears, or scuba divers where they try to hold their nose and force air through the station tube. This would be common. The air bubbles behind the tympanic membrane. It puts extra stress on the tympanic membrane and it hurts. This is somebody that would benefit greatly from some nasal steroids or maybe a Decadron shot or something like that to open that station tube and allow things to balance out. The bottom picture is cholesteatoma, and this is common when you have recurrent or untreated otitis media, and it is epithelial cells. These white cells here are just an accumulation of epithelial cells over time. And that will stay there the rest of their life. The problem is this part of the tympanic membrane is not able to vibrate anymore. So it eventually does impair the hearing, because essentially that part of the tympanic membrane is inflexible, so they can't hear from it. They can hear from the rest of it. And what is this? This is a sebaceous cyst right behind an ear. All right. Common abnormalities: otitis externa, acute otitis media, middle ear effusions, cholesteatoma, otosclerosis, Meniere's disease, and Lambrethitis are common ones. They're at the end of your chapter, and with descriptions, and they're throughout the chapter too, but a lot of these are at the end where you've got good pictures of them. Okay, realize that for the ears of infants and kids, inner ear development is in the first trimester. Infants' and external auditory canal is shorter than adults, and the station tube is wider, shorter, and more horizontal than adults. And so this is why kids can get bugs in easier to their inner ear, because the station tube, as well as the external canal, is shorter, wider, and more horizontal. So they can get bugs in through the station tube or the canal. And realize that the other thing about the mouth is they begin to salivate more by 3 months. So we're done with ears. Now we're going on to nose. I'll let you take a little quick break and be right back. Okay, the bridge of the nose. is this just gives you the points. The tip, anterior nostrils, the vestibule, and of the nose are the big ones. And the purpose of the nose is odor identification, and it's passage of inspired and expired air, humidification, filtration, warmth, and inspired air. There's resonance of laryngeal sounds that come through the nose. And there's some people that sound very nasal, and their pitch is too high in their voice, and it's bouncing off the top of their hard palate in the lower part of their nasal cavities. The other thing about the anatomy and physiology of the nose is the external nose, the bridge, the nares. You have sinuses, frontal, maxillary, and ethmoids. I'll show you pictures of that in a minute. And the internose, the septum, and I'm going to show you pictures of all these. All right, so here you have your frontal sinus. You realize that in the nose, you've got 3 turbinates, so you're looking for all 3 turbinates. Unless you put a spectrum in the nose, and a lot of people use the otoscope speculum, but if you just have it out here on the nares, you're not going to see the turbinates. You have to put it in the nose and tilt it back. It doesn't hurt, but that's what you need to do in order to make a difference. And to be able to see the turbinates. Realize when you go back, your light will not shine far enough for you to be able to see the eustachian tube opening without having a nasal speculum spreader that will spread this open, and you'll be able to see back there. And your sinuses are mucous membranes, and they've got to stay moist, and the average person produces about a quart of discharge every day out of their nose. Most of it goes down the back of your throat. And with more allergens, more allergic responses, it's going to be more than that. But I was surprised to figure out it was 1 quart. That's a lot of moisture to keep all this moist. I do want to bring out 2 things. You're going to get, here's the top teeth. Okay, you've got your uvula here. People ask what's the difference between uvulatus that hangs down and epiglottitis that's way down here where it opens, it cuts off from the respirations and or going to the stomach, the esophagus. All right, what's the difference on kids? The maxillary ethmoid sinuses are present at birth. Sphenoid sinuses are not fully developed until puberty. The frontal sinuses develop by 7 to 8 years old. You have deciduous teeth that appear at 6 to 24 months, and permanent teeth between 6 and 15-year-olds. And your third molar is often known as the wisdom teeth, come in about 18 years of age. So when you hit adulthood, a couple of things happen. The frontal part of your brain quits developing, and your wisdom teeth come in, and then most people will pull those wisdom teeth right out. Pregnant women, the capillaries in the nose, pharynx, ears, engorge due to the increased estrogen. So they have nasal stuffiness and a feeling of fullness in the ears. There's decreased smell, impaired hearing, epistaxis is common, nosebleeds. And you have increased vascularity and overgrowth of the gums, which causes the gums to bleed if you don't have a soft brush. And you can have laryngeal changes where there's hoarseness or a cough, and also vocal changes. And that goes away after birth within 2 months. Older adults. They have hair cell degenerations and stapes ossified, so they have hearing that deteriorates. There's the striae vascularitis atrophy, causing central neural hearing loss. And tympanic membranes become sclerotic, so you have conductive hearing loss. And the cerumen becomes dry, so it obstructs the ear canal, so once again you have hearing loss. So all this comes down to there's many reasons why there's hearing loss. Older adults are continuing cartilage formation in the ear and the nose. Your ear and your nose grow throughout your lifespan. So that's why you notice on some of the very elderly people, they seem to have really big ears and big noses that kind of droop down on the tip of their nose over time because that cartilage continues to develop. Soft tissues change and cheeks become more prominent, and that's because your cheeks tend to drop. As you age, everything drops. Gingival tissues become less elastic and more vulnerable to trauma. There's altered motor functioning of the tongue, making more difficult swallowing. And the saliva production decreases, and so you can have more dry mouth, lost teeth, and difficulty chewing, and their sensitivity to odors decline. And so it's also sensitivity to taste will decline. And the problem with that is they tend to use more salt, which increases their sodium. Why is there dizziness and vertigo? Well, there's a few reasons, but it can be due to increased pressure in the inner ear. It can be due to the fact that in the cervical spine that there's gradual narrowing of the foramen of the spine, especially with hyperextension of the neck. So what you want to know about the dizziness is the time, onset, duration of attacks, associated symptoms, if they felt any loss of consciousness particularly, and if they've felt dizzy, if they fell. And the other thing you want to ask about is medications. Any antihypertensive, any erectile dysfunction drugs, and any sleep or muscle relaxing drugs are known to do this. Any kind of muscle relaxant at all will do it. Earache. Onset, duration, pain, fever, discharge, concurrent upper respiratory infection, frequent swimming, and trauma to the head can cause earaches and related complaints. And ask about medications. What you really want to hone in on are antihistamines and decongestants. And if they're taking those and they've skipped a couple of days and they're getting an earache, they need decongested. And so adding a nasal steroid will open that station tube up, or a shot of steroids, but you can only do that 1 out of every 3 months. But that will get them over the hump, prednisone dose pack or something along that nature. Okay, hearing loss, risk factors, onset, cerumen impaction, environment for the best hearing. You want to ask them, is it in crowds? And that would be the sensory neural. If they can hear best in crowds, they've lost their bone conduction. They're hearing by bone conduction. They've lost air conduction. Sensory neuro would be the folks that cannot hear well in crowds. And sensory neuro are the ones that hear garbled sounds, and they have problems with word discrimination. Close words that all start with one letter kind of blur. Speech, management, if they have any problems with management of their hearing, and any medications that they're taking. Nasal discharge, look at the character, associated symptoms, seasonality of symptoms. One of the big things with the nasal discharge, and people will ask about the color, and that just means how long has it been oxygenated. And that that's not always conclusive, but what you do want to ask about is fever. You want to ask if there's tenderness over the sinuses and face, and if there's a post-nasal drip or daytime cough, because especially in the morning, if they wake up coughing, get up and get going throughout the day and they don't cough as much, they're dealing with a post-nasal drip at night. So give them something to dry them up and an antihistamine to keep them dry. And but decongestants often dry the mucus in the sinuses, making it worse down the road. But you can mix an antihistamine and nasal steroid and get a lot of mileage out of those two drugs, especially when combined. Snoring, if there's any change in the snoring patterns or complaints of snoring loudness by their partner, and if there's any history of obstructive sleep apnea or medications. If there's not a history of obstructive sleep apnea, here's one of the things that you really ask them about. The snoring, irregular breathing heard by a partner, they wake up with a headache and daytime fatigue. And if that is the case, a sleep study might get you a lot of places. It really will make a difference on the patient's life. And it's been proven to decrease diabetes and blood pressure, the likelihood of diabetes and blood pressure issues. Equilibrium. You're going to do that by the Romberg test, cold choleric test, or the cold choleric test is quite brutal, as is the Milan-Barany test, because with that you're going to shake the head in certain positions, and you're going to put them on their back, tilt their head over the edge of the table, shift to the left, shift to the right, back to the left, and see if you make them dizzy. And if you do, then you've got one dizzy person that's going to sit in that exam room for a while. So I would just go with the Romberg. Why make them dizzy and puke in your office? Romberg will give you the equilibrium, and you can have them walk heel to toe and other equilibrium tests that are easier. But this is all the Barany test is real common whenever you are looking at inner ear functioning. Okay, so that's it with the ear. Now let's go to the nose. External nose, you inspect and palpate for shape, color, discharge, patency, and the sense of smell, which is cranial nerve 1. You can have the nasal cavity and the inferior and middle turbinates and the nasal mucosa, sinuses. You can palpate and percuss those sinuses. The nose, you're going to inspect for symmetry, positioning, determine nasal patency, and examine sinuses is unnecessary in infants. Realize that the pediatric versus adult sinuses, the ethmoids are underdeveloped compared to the adult, and there's no frontal sinuses on the kids. And when does this change? It's closer to later adolescence, adulthood, when the cranium and the face grows and the cranium quits growing in young adulthood. All right, you're going to start off with percussing your sinuses to see if you have any tenderness. And you can just tap with a finger. You want to ask about nosebleeds, frequency, amount of bleeding, nasal obstruction, treatment difficulty, especially with stopping bleeding, predisposing factors, site of bleeding, and medications. To transilluminate the sinuses, there are several ways to do it. The easiest is turn out the light, but turn on your illumination factor first. You can use your otoscope, or this is a transillumination tool. What it has is pictures where you cover the eye and then go underneath, but turning out the lights will make the biggest difference. Okay, then you want to go ahead and put the speculum in the nose, and by in the nose I mean in the nostril. And you realize here you're seeing a polyp. Over here is a turbinate. This polyp is shiny bright. Okay? And you go in, and this is a pretty erythemic nair. So how are you going to know what color the nair should be? And what color should the mucous membrane of the sinuses be? It's one shade redder than the cheek, inside of the cheek. So look in the mouth first, and then go to the nose. You see that you got purulent, creamy white discharge in the bottom left corner. Okay. And oral pharynx. You've got the tongue, teeth, gums, uvula, hard and soft palates, and the vestibule, and the salivatory glands, parotid, the submandibular, sublingual, and the oral pharynx, and your tonsils. You want to notice on the mouth, the lips, the buccal mucosa, teeth, gums, and the Stinson's duct. Oral cavity, look at your tongue, that's cranial nerve number 12, the palate and the uvula, and the oral pharynx. Dental problems, ask about pain, tooth grinding, temporomandibular joint problems, swollen, bleeding gums, ulcers, and dental dentures and dental appliances, malocclusions, and medications. The mouth, look for timing, duration, pain, associated factors. Tongue character. You want to see if it's well hydrated, if it's glossy, and if it's got fissures. And medications. Because medications, especially antibiotics, can cause a hairy tongue, which comes in basically two colors. It can be yellow, which is pretty odd, but it does come out yellow, or black. Treatment is stop the antibiotic, and it will go away. But it kind of freaks most people out. They got a yellow-looking tongue. Sore throat. You can have pain on swallowing associated with upper respiratory symptoms is common. Postnasal drip. Mouth breathing. Exposure to dry heat, smoke, and fumes, hoarseness, and medications. You can have difficulty swallowing, solid, liquids, tightness, substernal fullness, vomiting, drooling, aspiration when swallowing, or swallowing liquids and then they come out of the nose whenever they start to laugh or anything. And that's one of the problems for people that have difficulty swallowing. That's one of the earlier symptoms. Okay, so now we're going on to the mouth. Look at lips, shapes, and regularities. And if you look at lips, you've got a couple of pictures in your book. One is on page 321, and the other one is on 315. And you're going to see if there's drooling. And drooling can lead you to suspect Down syndrome, mental retardation, or drooling, if it goes on, can be angular cellulitis. Can all end up just due to the moisture that's there. Inspect the gums, teeth, and tongue, and inspect the palental arch or soft palate, and evaluate the suck reflex. You can go ahead and palpate the sinuses, mouth, inspect for decaying, grinding teeth, check gag reflex, which is cranial nerve number 9 and 10, but just gag them, and then inspect the tonsils and the epiglottis. One gag reflex and you'll be able to see the entire back of the throat on most children. All right. Oral pharynx functions, emissions of air for vocalization, passage of fluid, of foods, liquid, saliva, taste. All right, so we're going to go into a couple of alterations in the mouth. And this right here is what they call canker sores or aphanthus ulcers. And if you look at this lower picture, it has got angular cellulitis, and that is because this person is drooling. And what you've got on the upper picture is herpes, but you can't see that picture real well. You've got a better picture in your book. Okay, the top picture is a hairy tongue, and this is in black. And how long after an antibiotic does that occur? It can be as short as a day. How long does it take to go away? About 2 to 3 days. Usually 3 days after they stop the antibiotic, it's gone. You see a sublingual hematoma that's underneath the tongue in the bottom picture. On the top picture here, you've got this one in your book. The top picture is Taurus palantinus, and it's on page 318. And this is a normal finding. It means Arab Saturn, and but it's a normal finding in people, and so this is just something you chart, and that's all you need to do on it. It's not a tumor. And on the back, the bottom picture, looking at the posterior pharynx, you see on the anterior pharynx up here, there is no erythema. It's all one color. The uvula, all one color. The pharyngeal arch right here, all one color. But when you look back here, it looks like little spots. And this is what is called cobblestoning. This means that they have got an allergic response or postnasal drip. It doesn't mean that they have any kind of infection. You need to treat the allergies and the postnasal drip, and that will go away. Does a postnasal drip end up in a sore throat? Yes, it does. So you just have to look at it and see if there's any erythema that goes with it. And there is none in this picture. They've got allergies, treat the allergies. All right, tonsils. How do you grade tonsils, and what is that? Tonsils is the lymph gland that you can see. And you have a tonsil here, and if it comes out, this is a 1+. And you're all looking at the uvula, and you're looking this comes out to about a 2+. This is a 3+. It's not touching. 4+, they're practically touching. So what do you do about enlarged tonsils? Well, if there's not any problem, you do nothing. Because a lot of people have large tonsils. Now, large tonsils are a catcher's mitt that keep all the bugs from going down into the lower respiratory tract. But one of the problems is you often get food at the very bottom of the tonsils and a peritonsillar sac. See how there's little pock marks on the tonsils? Well, you get food back down in there, and they will hurt. The tonsil will hurt and irritate. What you can do is get one of those long Q-tips. And you always want to go in, go from the back, and come forward. Because what will happen is, you don't want to flick something down their trachea. But why I like to go from the back, that will make them gag, and you've got just a second to swipe forward and knock anything off that's down in there. What's real common is crackers, and what's real common in kids are those little fish crackers that they eat. All right, on kids, look at the ears, nose, sinus, mouth. Same on infants, pregnant women, and the older adult, look at functional assessments. Realize that these teeth are called bottle teeth because they've had a bottle in right over the two front teeth. Here's a cleft palate. As I said, this happens in the 12th week of gestation, but the hard palate has not bridged, and that will take a surgical intervention. All right, you've got this picture in your book, and if you look here, see how red these gums are? That's gingivitis. And this is even a worse gingivitis because you see all this edema that's happened all around the teeth. Okay, and right here you've got labiitis, and you've got a picture of this in your book on 315 somewhere in there. Oh, here it is, 317. And so you've got this picture in the bottom right-hand corner. And this picture happens to be glossostomatitis, lesions on the tongue, with lesions on the tongue. And sometimes you're going to see a lot of people, it's not in this picture, but pretend you see a little bit of erythema there. And that happens to be people that always are constantly licking their lips. But these two pictures on the right are glossitis. And so you do have a picture in the book on page 317. That's picture B. And it has a geographic tongue. It looks like there's a map on the tongue. That is nothing but something to record in the chart. It's a normal, benign finding. It's just their genetics. Okay, what do you find in infants? And what are you going to worry about? Well, if you look here at picture A, that's thrush. Picture B is your preemie teeth, your first teeth. And C, you've got an Epstein pearl, but it's not near as good as this E, where you see all these little Epstein pearls. Now, these Epstein pearls are called baby teeth. You take a pair of forceps and just pluck those things out so they don't swallow them. And in D, you've got an enlarged tongue, macroglossia. And that enlarged tongue is going to be, it's common with Down syndrome. Okay, looking at some lip findings. Picture A over here, you've got angular cellulitis. This is somebody that drools a lot. And right here, this is a better picture, of the herpes on the lips. And C, you've got a little angioedema going on. E, you've got a squamous cell carcinoma right there. And F. Okay, F is Peutz-Jeghers syndrome, and pretty serious. Okay, older adult findings. This is a fissured tongue. It's normal. You're going to see that as they lift this up, sometimes they've got some bulging of underneath their tongue, but it's not discolored. It's kind of hard to see in that picture. Here you've got some varicosities under the tongue, and this is a normal finding of aging. It's a little bit better than the picture on the bottom. Okay, oral findings. Here is your cobblestone throat. Because look at the rest of the pharyngeal arch, uvula, it's all the same color. So that's cobblestoning allergies. Going to the left, woo, look at that pus. We got ourselves some tonsillitis, and look at that erythema there. So we've got pharyngitis, tonsillitis. Look at this. This is almost touching. It's a 3+, 4+, tonsillitis, tonsillitis, pharyngitis with an abscess. So that one's more serious. This is somebody that's going to have problems and with their voice and swallowing. You need to give them a shot of some penicillin, because strep is the #1 problem. You have the #1 bug in that area. Okay, you want to we want to have a couple of reminder slides at the end. Always on kids, you want to do the invasive part, the ears, nose, and throat, last. You want to go ahead and do the heart, lungs, abdomen, muscular, skeletal, everything else, and come back to the head last on kids. On a kid that is under 2 years old, you're going to pull the auricle down to view the tympanic membrane. It's going to be down and back, posterior. Evaluate toddler's hearing by observing response to whispering and noisemakers. Be sure and evaluate speech development. Get the child to talk, or try to. You're going to do the Weber and Rhine after age 3, and you're going to send them to audiometry for all, are performed on all newborns to test their hearing. Pregnant women, inspect the nose pharynx for edema, erythema, and you would expect that. Inspect tympanic membranes and see if there's any retracting or bulging. There shouldn't be. And inspect the gums for hypertrophy, and that would be typical. And inspect for nasal congestion and sinusitis. Now, there might be nasal congestion, but it doesn't tend to turn into sinusitis just because they're pregnant. It's because there's other bacteria that's been sitting there for a while. Okay, on older adults, realize if hearing aid isn't worn, you have to inspect the canal for irritation or cerumen impaction. Inspect for coarse hair on the auricle, and inspect the tympanic membrane for sclerotic changes. Note the presence of the presbicuspis and conductive hearing loss, and inspect for cerumen impaction on the elderly. Nose, look for dry mucosa, inspect for increased hairs in the vestibules of men. Mouth, look for reduced salivatory flow, and check for thinning in the buccal mucosa. Examine the tongue for fissures, varicosity in veins, and examine dentures for occlusion. On the nose, realize that sinusitis is common, and cocaine abuse, and that will cause cocaine abuse initially. If they've just snorted it, will have a runny, white, clear discharge, and their blood pressure tends to be higher. And as they use the cocaine for over time, it will corrode the septum of their nose. So in between the two sides of the nose, you can see a hole. Other common abnormalities of the mouth and the oral pharynx, look for tonsillitis, peritonsillar abscess. I showed you a picture of that. Sleep apnea, and kids look for a cleft palate. Older adults, the presbycusis and the xerostomia. Thank you. That is the end.